Good morning. I'm going to talk to you about double row repair, why and how. Okay, so what are the goals for rotator cuff repair? Well, we have a lot of goals for rotator cuff repair, but truthfully, no matter what the tear looks like, whether it's a simple tear or this more complex, delaminated, degenerative tear that you see here, we have the same goals. We have mechanical goals. We want to have good mechanical strength of the construct. We want to restore the footprint. We want to get adequate contact pressure of the tendon to bone. As you heard about this morning, more and more we have biologic goals. So we want to optimize the healing environment, whether it's using vented anchors or adding PRP or bone marrow. And then if you work in a surgery center, if you have a busy practice, you have utility goals. You want the technique to be quick and efficient. You want your techs to know what they're doing and make it easy for them. You want one system that's going to work for all kinds of tear patterns, and ideally the system should be cost effective. So I want to tell you why this is my go-to. The SpeedBridge is really the gold standard. It's a workhorse for rotator cuff repair. It's adaptable, it's expandable. You can use it for all different kinds of tear patterns. It provides really secure initial fixation. You also have multiple anchor options. For really hard bone, you can tap the bone. For really soft bone, you can use a smaller punch or a larger anchor. Metal tips for self-punching are available. It's still a ways down the road, but they're working on self-punching peak tips. Now we know we have fiber tack anchors that we can utilize, as well as knotless swivel locks. So it's really changing the game. We have that same system, but we're able to continue to improve upon how we're able to get fixation. The literature really shows that the biomechanical evidence favors a suture bridge or transosseous technique over a single row or a double row. We know that this technique provides higher failure loads, greater contact pressure, but it is important to note that so far we really don't have clinical differences between these techniques. The important thing to realize is even the level 1 studies are pretty underpowered, so they may be prone to type 2 error. We also know we have the option of a knotted versus knotless suture bridge. So we have the option of tying medial knots. And it is true that the biomechanical studies show that medial knots, and now with the knotless, potentially the medial pulleys or medial compression, will increase the stiffness of the construct, increase the ultimate load to failure, and gap formation in cadaveric models. However, there is some concern that making this construct too stiff may be what's contributing to type 2 re-tear, the re-tear at the musculotendinous junction, and as we all know, that can be a really difficult problem to manage. Dr. Park also looked at the biomechanics of a knotted versus knotless suture bridge technique, and interestingly, the knots actually had an adverse biomechanical effect by inhibiting self-reinforcement. So what is the self-reinforcement? Self-reinforcement in suture bridge is basically a mechanism by which the tensile forces on the tendon translate to compressive forces at the footprint. And it's thought to do this by changing the shape of the sutures from more rectangular to trapezoidal, decreasing that alpha angle that you see there, and basically wedging the tendon against the bone, increasing frictional resistance and increasing resistance to failure of the construct. So another study done by Smith in 2017 showed that whether you tie knots or not, whether you secure down that medial row, increasing tension on the repair does increase the footprint contact pressure for both groups, but the self-reinforcement was enhanced in the knotless group. And there was no difference between these two techniques in yield load, stiffness, ultimate failure. So while the cadaveric studies can be helpful, it's always really important to think about how this is going to work in an actual patient. So Dr. Millett looked at 151 patients and compared a technique in which he had used knotless tape bridge technique to a knotted suture bridge technique. And again, no clinical differences can be found between these techniques. They both had good clinical outcomes, good functional outcomes, but in his study, the knotless tape technique was less likely to have a full thickness rotator cuff tear on MRI follow-up. So this is why I use the SpeedBridge. It really is a workhorse. It provides excellent initial fixation for me. It's very efficient in the OR. It comes in kits. Now the kits are packaged with the needle. My techs know what to expect. Everything is there for them. It's reproducible. It's flexible and adaptable from small to very large tears. I get good clinical outcomes. So currently, I prefer the SpeedBridge with a knotless tape technique, and I will augment with collagen or with biologics as I see fit, depending on the patient. So how do I do a speed bridge? This is a 65-year-old woman with a really large rotator cuff tear, but as you can see, the articular surfaces look pretty good. So she did want to avoid reverse. This is a pretty large tear. So typically what I'll do is medialize off the articular margin. I like to use traction stitches to help pull the rotator cuff over. Typically when I do this, I will incorporate the biceps into my anteromedial anchor. You can see that I like to use the fiber links to pull the tissue over, and that's going to help me realize that this patient actually needs an expanded speed bridge. So in this case, I'm actually going to place 3 medial row anchors and 3 lateral row anchors due to the size of the tear. I can use those traction stitches to help place my permanent stitches, and then as I get those permanent stitches into place, I can start to see how that cuff is going to mobilize over to the tuberosity, and it looks like there'll be enough cuff to get coverage. Another great thing about the speed bridge that you heard is that you have different options with anchors. So here I'm actually using a smaller punch, and then as you see it go down, this will be a larger anchor than the standard speed bridge with the blue handle, and I'll do that because of the bone quality. Another nice tip is that if you throw in those fiber link traction sutures, you can incorporate them into the lateral row. It's just more fixation, it's easy, it really adds no extra time. And then here on this posterolateral anchor, I'm just demonstrating the technique by which you tension each suture individually so that you can be sure you get great initial footprint contact pressure and a great initial footprint area. So putting that last anchor in, you can see that I did no special slides or techniques, and you can see I got full coverage of this humeral head with reasonable tissue across the entire footprint area, starting out with what really looked like a bald eagle situation. So just the basic speed bridge works great for me. It really is a gold standard in my hands. There's a lot of variations, so we're starting to hear about them now. It's always exciting to look at new things. And so here, this footprint, you can see it's a much smaller area of footprint exposed. So in this case, I use the 2.6 millimeter fiber tacks. They just make a much smaller hole. I even had room to put a third one if I wanted. Once those are passed, you can just incorporate them into the lateral row just like you would with your standard speed bridge. With regard to dog ears, I like the fiber links. So here you can see the stitches are in place, but I've got some anterior tissue that isn't fully secured. So if I just throw a fiber link in and then pull it over to the lateral row, you can use that for a dog ear. And that's actually before I put the second anchor down in the lateral row. And you can see I already have great compression that's even across the footprint, and that's before I even finish the repair. You're hearing a lot today about the knotless techniques. There's so many options. You can use it for a medial pulley, a medial ripstop. You can use those knotless anchors to secure your dog ears. So the knotless speed bridge is going to give us even more opportunities for fixation using the same construct that we already use and that we're already all very familiar with. So I highly recommend that you play around with that. A few technical pearls, and a lot of these you've heard from my colleagues as well. I like 4 portals, so I put 2 portals kind of on the 25-yard line laterally. I like to use the 70-degree scope as it kind of gives me a bird's eye view. I do use a tissue grasper to plan and assess, but as you saw from my videos, I'm really liberal with use of the fiber links for traction sutures. They really are easy to throw in and then allow you to put traction, and you can incorporate them into the repair. I generally work from anterior to posterior. For me, I like to save time by not shuttling the stitches a lot, so I keep them all in the same portal. But as you can see, I have to have my assistant holding tension on those stitches, pulling them toward the elbow. So whether you do beach chair or lateral, keep them down toward the elbow and then just bring your scorpion up over and work above the stitches. I do it the same way every time, working from anterior to posterior. Usually the tears are going to be retracted posteromedially, and so I'll be pulling them anterolaterally. I did want to briefly mention the SOS system. If your institution or organization allows you to participate, this is a HIPAA-compliant way that you can enroll your patients and get patient-reported outcome measures. So you can use this on a tablet, phone. It's really easy for you and your patients to use, and it will give you some leverage because you get these patient-reported outcome measures and can track your patients over time and compare how your patients do overall compared to national or global data. I would mention that patient-reported outcome measures are coming. It really looks like we are going to need to be providing this information before we can get approval for procedures. I really believe that's on the horizon. So it might be important to think about how you're going to incorporate that into your practice. And this is an easy, painless way to do it that really requires very little effort on the part of you or your staff. So looking at the SpeedBridge, again, when we look at them versus single row repair, even with the SOS data, patient-reported outcome measures track pretty evenly at about 2 years, but we're starting to see some divergence over time. This is for the visual analog scale for pain. We see the same thing with a SANE score, starting to diverge over time. So another nice thing about the SOS system is it really may be a powerful tool for us to understand how these patients are going to do long-term, because we want our patients to be doing well, not just 1 year, 2 year, but hopefully 5 and 10 years still with intact repairs. Thank you.